So this is actually from Montana. This is south of where I live in Billings. This is the Beartooth Highway. It's when you come up from the Red Lodge side, you basically wind up the side of this mountain to 10,000 feet, and then from there go down into Yellowstone National Park. Very pretty drive. Just make sure that your driver is paying attention to the road. So this is up a lake up at the top of it, around the top of it. So this is liver failure and cirrhosis. Cirrhosis is actually one of my more favorite topics. It's just kind of interesting the different complications that can occur as a result of cirrhosis and that. And so this will be general features. And we talked about some of the underlying causes for cirrhosis with the hepatitis lecture, or depending upon how you review them, we'll talk about that with the but this is kind of just general features. So the two websites are me and Dr. Hughes' sites for USMLE questions. I am, with making these lectures on YouTube, I am going to try and do more with adding questions to that website, and also more with my Twitter account and stuff like that, posting when I put these up, put more unknowns and stuff like that, try and get back into getting information out to you guys as best as possible. So I have a strong interest in general organ pathology. I really like natural disease. And I think as a forensic pathologist, I see a broad range of natural disease, and I kind of see a lot of stuff. I think I know a lot of stuff superficially. Like one of the internal medicine residents who trained me said, I'm a jack of all trades, master of none. That's kind of the way I feel. So I think for teaching medical students, it's easier because I tend to stay more basic and not get into kind of the specifics and stuff you don't necessarily need, which I've seen in a lot of lectures I've seen to medical students. So if you would pause, read my disclaimers, make sure they don't apply to you. If they do apply to you, don't view the lecture. One more, pause, read this again, and if it doesn't apply to you, great. If it does, please don't view the lecture. And then, like I said, if you want to know about my teaching method, I described it kind of in the introduction, so you kind of understand why I'm doing what I'm doing. I kind of explain with each lecture as I go through and everything like that. And then here are my references. All are excellent books. There's one question at the beginning. Like I said, the purpose of this is that usually you're not supposed to know the information. It's to make you think about it, and then it kind of clues you in as you go through the lecture. You're trying to figure out what the answer to the question is, and it increases retention. So we'll go through at the end. So we're going to talk about liver failure. So acute liver failure is basically when the time from the initial diagnosis of liver disease to hepatic encephalopathy is 6 months. If it's 2 weeks, it's fulminant hepatic failure, and if it's less than 3 months, it's subfulminant hepatic failure. So this is when you have it very quickly. In the United States, it says basically acetaminophen overdose is responsible for about 50% of cases. The others, there's a broad range. The various forms of hepatitis can be associated with acute liver failure. A or B can, autoimmune, drugs or toxins are also high on the list. There's a long list of things that can potentially do it. Morphologically, you see massive hepatic necrosis, and because of it, you get jaundice, and along with that, icterus, scleral icterus. And then you'll see hepatic encephalopathy. You can see coagulopathy. So the interesting thing is the liver has, for the longest time, kind of the dogma is if your liver failures, you have a problem with clotting because it makes clotting factors. But if you read some of the newer literature and everything like that, it basically says that people with like cirrhosis, yes, they don't make clotting factors as well, but at the same time, they're also procoagulant. It kind of balances out. So it's kind of a neat topic because in the past, it's always been believed that if they have cirrhosis or something like that, they're probably coagulopathic because they're not making clotting factors. And it's a little more complex than that, kind of just an interesting topic. They can get portal hypertension and then hepatorenal syndrome as well too, and we'll talk about hepatic encephalopathy and hepatorenal. So this is a person with acute liver failure. So the liver normally the capsule is pretty tense, and I mean not tense like bulging out, but it's usually pretty flat. Here you can see, especially at the yellow arrow, you can see wrinkles. So that would imply to you that the underlying parenchyma is absent and missing. I have seen a really good case of acute liver failure that I unfortunately don't have a gross picture of, but the whole liver was just markedly wrinkled, and underlying it was massive necrosis. But this one does serve the purpose. So you understand that if the hepatocytes are underlying or absent necrotic, that the surface will kind of then become wrinkled because there's less tissue underneath. So hepatic encephalopathy is something that's associated with liver failure. You get a range of neurological manifestations from behavioral changes to coma, so a broad range. Characteristic thing is the asterixis, where the hands will rapidly flex and extend when held out. And then hepatorenal syndrome is just simply renal failure in patients with liver failure. So in a patient with liver failure, you'd want to test BUN and creatinine and see how the kidney function is. So with liver failure, one of the common things you see is jaundice. If it's in the conjunctiva, you can call it scleral icterus. The conjunctiva is actually the best place to look. It's one of the earliest places that you will see it. So sometimes you'll see yellowing in the eyes, but not of the skin. So the arm there is mine. I'm a fourth generation Montanan, but you can see the tan pink of my skin compared to the yellow of the decedent with jaundice. So acetaminophen overdose, as I said, in the United States, about 50% of acute liver failure is due to this. So I put down at the bottom normal liver. The yellow arrows in all of them show the centrilobular region. The black show the portal triads. So if you look at the two areas where the damage is occurring, at the black arrow you see some purple. So there are hepatocytes around the portal tract that are surviving. Now, it's amazing because what happens is with toxins will usually come in and damage the portal tract hepatocytes first because they hit them first. But acetaminophen is actually not the toxin, it's metabolite. So as it moves through the liver and is metabolized, that's where it starts doing the damage. This would be similar to what you'd see in people with centrilobular necrosis, with the idea being of oxygenated blood, best at the portal tract, worst at the central lobule. But that's how this works with acetaminophen. Okay, this is that Beartooth Highway. This is going up for the Red Lodge side. Like I said, it just kind of winds back and forth, gaining like 5,000 or 6,000 feet up to 10,000 feet on this side. And so looking down, that is the road below us. So like I said, you want to make sure the driver's paying attention to the road when you drive this. Very scenic, very beautiful. I always tell people if you're in Montana, it's one of my top ones to go on. So with chronic liver failure, this is liver failure occurring over a prolonged period of time. Similar list of things that can cause it: the hepatitis viruses, B and C, non-alcoholic fatty liver disease, diabetes mellitus, and obesity is two of the main causes of that. And then alcoholic liver disease, others as well too. We talked about hemochromatosis, or we'll talk about or have talked about hemochromatosis, alpha antitrypsin, Wilson disease, and their underlying etiology of cirrhosis. Clinical features, oftentimes it's asymptomatic until a late stage. You can see non-specific features like weight loss, weakness, and then just features of liver failure. They can develop hepatic encephalopathy, they can develop hepatorenal, they can be jaundice, they can develop scleroicterus, they can develop a coagulopathy. Morphologic features with chronic liver failure, usually talking about cirrhosis stage, and then the manifestations of cirrhosis we'll go through. And then other things, you can see jaundice, of course, because the inability to get the bilirubin once it's conjugated out, or to conjugate the bilirubin. And then with jaundice, you can get pruritus. Portal hypertension, as the liver becomes scarred, my thought is then it's tougher for the for the blood to drain through it, and so it'll take alternate routes. And so with portal hypertension, you'll see esophageal varices, you'll see hemorrhoids, you'll see caput medusae. You can get hyperestrogenemia, which can cause gynecomastia in males. And then cirrhosis is a risk factor for hepatocellular carcinoma. My understanding is that basically if you have hepatocellular carcinoma in an older individual, you're essentially always going to have cirrhosis. It'd be very unusual to see hepatocellular without an underlying cirrhosis. So grossly, there's basically two types of cirrhosis: micronodular and macronodular. Macronodular are basically associated with all of them. Micronodular is more commonly associated with alcoholics. We see a lot of chronic alcoholics at autopsy, see a lot of micronodular cirrhosis, and sometimes it can be very difficult to identify. The nodules are very small, less than 3 millimeters, and sometimes I require putting it under the microscope to actually pick up the cirrhosis. Macronodular, pretty easy to see with the naked eye. So with cirrhosis, you can get a variety of features. Splenomegaly, basically because of the portal hypertension, blood congests back into the spleen and you'll get enlargement of the spleen. I've seen situations where the liver and spleen were almost the same size. Portal hypertension, as I just mentioned, basically when because the liver's scarred, so it's hard for blood to go back through it, is my thought process on that. So basically what happens is it backs up fluids, you get ascites. Hypoalbuminemia associated with liver also contributes to ascites. And then the blood will take alternate routes. So you get esophageal varices, caput medusae, blood vessels in the abdominal wall, and then hemorrhoids as well. Hyperestrogenemia due to impaired estrogen metabolism leading to gynecomastia. And then, like I said, a risk for hepatocellular carcinoma. So this would be ascites. So to the left of it, this is an individual. You can see their abdomen is swollen, and you can pick it up clinically, obviously, what they describe as a fluid wave. And when you push on the belly, you can actually see what looks like a wave of fluid. Most times I see maybe 1 liter, 2, 3 liters in there. The record I ever saw was 26 liters of fluid in the peritoneal cavity in somebody with cirrhosis. To the right of it, you can see the open peritoneal cavity. You see the intestine there, and you see the fluid. And then at the bottom, that's where we've ladled it out, and you see. So it's usually this watery, clear, yellow fluid. These are esophageal varices, top left. To the left of it, you can see the cirrhosis. To the right of it, you can see what I've done is I've turned the esophagus and stomach inside out. What that does is it leaves pressure, they say, on the veins, and so it leaves them distended a little bit. I don't know. It does help. I think sometimes just you don't want to cut through it because you're going to cut through the area of interest when you do that. It's just the way it happens. But you see vessels there, and you should not see vessels at the gastroesophageal junction. To the right of it, there's also some esophageal varices. They were ruptured, and the individual bled from this. To the top left, it's hard to see, but there were some faint, large blue veins on the abdominal wall there, which I would say would be caput medusae. This was a person with cirrhosis due to chronic alcoholism. You can also see portal vein thrombosis to the right of it. In the background, you can see a green liver. This liver was so green, when we saved a section of it, it actually turned the other organs in the formalin green as well. But you can see the portal thrombosis there. Splenomegaly at the top left, you can see the cirrhotic liver, and then the spleen's enlarged. That's basically along the lines of the portal hypertension, the difficulty getting blood back through the liver because it's fibrotic. So scarred, and then so basically blood will congest, build up in the spleen, and gets enlargement of it. And then when you get the ascites, usually it is like I said, a clear, watery yellow fluid, but it can get infected. And this is what's called spontaneous bacterial peritonitis. So this individual to the left of it, you can see the cirrhotic liver peeking through there. And then basically that's the omentum, and you can see all the inflamed fibrinous material on it. So this was spontaneous bacterial peritonitis, which can occur in people with ascites. So we've talked about acute liver failure and chronic liver failure. You can also have acute on chronic liver failure. So what happens in this case is you have a person with chronic liver failure, so they have cirrhosis, and then something else hits them, and they get acute liver failure on top of it. So kind of like the idea of the borderline patient, they have some other stressor. So, a person with hepatitis B cirrhosis who then gets a hepatitis D superinfection of that, and the mortality rate is high. So I will see this sometimes at autopsy. People, it seems like who survive for a period of while who are hypoperfused. But you can see top left and bottom right, you can see the nodularity of it, the cirrhosis, and then the black arrows indicate areas of necrosis. So you can see from this power, they're not basophilic cells, they're eosinophilic, there's some inflammation there, it's congested. So this would be an example of what would be causing acute on chronic liver failure. They're cirrhotic, so they have chronic liver failure, and then they have the acute necrosis on top of it, so that's the acute on chronic liver failure. Okay, so with the question, so pause, and then we'll answer it. A 43-year-old chronic alcoholic is found dead in the bathroom of his apartment. In the toilet, on the floor of the bathroom, and the hallway outside the bathroom is a large amount of blood. An autopsy is performed and reveals 1 liter of blood in the stomach and cirrhosis of the liver. A perforated vessel was identified. Of the following, what was the underlying mechanism by which the pathologic lesion leading to the hemorrhage developed? So the person has cirrhosis, they have esophageal varices, that's due to portal hypertension. Okay, so once again, use reflection. Think back what were 5 important points that were made during the lecture. And once again, I always hope I make 5 important points at least. This is from Make It Stick. Like I said, they gave an example of a medical student went from bottom of the class, top of class using this one technique. So I very much promote it. That's why I don't use summary slides or anything like that. I want you to think about and summarize the lecture to yourself, and it will help with your retention of the material. So this is when I lived in Missoula, when I worked in Missoula. This was my wife and I would walk sometimes down to the gas station or the restaurants below us and stuff like that. And then every once in a while, we had a lot of deer in the neighborhood and stuff like that. And so this one just saw a little buck outside the house and stuff. So I hope this lecture has been useful, and thank you.